Hey everybody, Dr. Reviso here, and in this video we're going to talk about the renin angiotensin aldosterone system. And I know it kind of looks simple here, where we're just talking about regulation and the direct pharmacological targets, but there really is a lot to the fundamentals of this system. If you can understand this system and a lot of what we're going to talk about in this video, then a lot of the renal and the rest of the cardio section will actually make a lot of sense. So let's try and break things down. We'll start with renin and just kind of see where this whole process comes from. And again, really the mediators of this are all in the name. Renin, angiotensin, aldosterone, right? These are the three major mediators we're going to focus on. Like I said, this looks really complicated, and I know this isn't a kidney lecture, but we have to at least acknowledge some of what's happening on the renal side to understand what's happening with this system. This is all really going to start in the kidney at the juxtaglomerular apparatus. And this always used to kind of confuse me because, it's always like, well, what is the juxtaglomerular apparatus? So it's really made up of three components, and I think this picture outlines it really nicely. So the juxtaglomerular apparatus, this structure here, is going to be made up of three substructures. So the first one is the macula densa, which is kind of this region over here. That's the macula densa. And essentially, the macula densa is a portion of the nephron that we haven't talked about yet. This is the distal convoluted tubule. You're going to have some blood coming through, right, from the arterial side, going through this afferent arteriole. It's going to get filtered here in the glomerulus, and this filtrate is going to go into the nephron, right? So this is going to be the proximal tubule. You're going to have your loop of Henle, right? And then if you can imagine, kind of coming out of the page here is the distal convoluted tubule. Okay, so that nephron is going to kind of loop around, and that distal convoluted tubule is going to come back to the site of where that initial blood came into the glomerulus at the site of the afferent arteriole. So that's where these epithelial cells that are abutting against the afferent arteriole, that's the macula densa, and this is one of three components of the juxtaglomerular apparatus. The significance of the macula densa is that this structure is essentially detecting the sodium and chloride concentrations, but I really want you to just focus on the sodium concentration. So it's primarily detecting sodium concentrations. We'll talk about why that's important in a second. The second structure of the juxtaglomerular apparatus, and I'm going to try and color code these so I don't confuse you. So let's use a different color for the granular cells. So the granular cells are going to be sometimes referred to as the JG cells or the juxtaglomerular cells. In other words, these are kind of like the primary cells of the juxtaglomerular apparatus. And what's really significant about these cells is that these cells will actually release renin. Okay, so the juxtaglomerular cells will actually release the renin that kicks off this whole cascade. So this renin is going to get released from the granular cells or the JG cells of the juxtaglomerular apparatus. Finally, we have one other component here, and that's the mesangium extraglomerular cells. So these cells are kind of, in the vicinity of this juxtaglomerular apparatus, but don't really have as high yield of functions as the macula densa and the JG cells. Okay, so the primary cell that we're interested in this lecture is going to be the granular cells, because those are the cells that are releasing renin. Now, the macula densa actually affects the regulation of the release of renin. It's so close. If you can see the granular cells are right here in green, and then you can see that the macula densa is right up against those granular cells. So essentially, the macula densa will detect the sodium concentrations in the lumen of this tubule. So the macula densa will sense the sodium inside of this lumen. If that sodium concentration is low in the lumen of the distal convoluted tubule, what is that telling you? Well, if sodium concentrations are low, remember, water follows salt. Think of salt or sodium as a surrogate for water. Okay, and think of water in general as a surrogate for blood volume. Now, that's not always true. We'll talk about exceptions to that. But when you see low sodium, you think low blood volume. That's what the kidney thinks. It sees low sodium, it thinks about low blood volume. So the kidney thinks that the blood volume is low, and so the kidney is going to respond by trying to increase blood volume. Okay, and we'll talk about what that does in a second. Now, if the sodium concentration is high, on the other hand, then we would want to do the opposite effect. We would want to decrease blood volume. The way I want you to think about the RAS system, we'll go into details on it, but just to put it simple, okay, just remember, if you can't remember anything else, the RAS system is involved with increasing your blood pressure. If you can remember that, you've already won half the battle. Now, we can be specific and we could say, okay, it increases the total peripheral resistance through vasoconstriction, okay, primarily going to be alpha-1 mediated, and then it's also going to increase your preload, right? And it's going to do this by increasing your blood volume by increasing what? Well, it's going to have aldosterone, right? It's in the name renin angiotensin aldosterone system, and aldosterone is going to increase your sodium reabsorption. So in other words, we're going to have increased sodium in our blood, and remember, water follows salt. That's going to give us higher levels of water or blood volume, right? And we know that blood volume, if I have more blood volume going back to the ventricles, that's going to increase my preload. Okay, and that's then going to increase my stroke volume and my cardiac output. Okay, so this is the general concept. Now, I know this is really complicated, but like I said, the simple way to think about it is it increases your blood pressure, right? It's going to increase your preload. It's going to increase your total peripheral resistance. And we're going to talk about how it does all of this here in a second. But how does this process start off? Let's go back to the granular cells here. How does this process start off? It starts off with the first letter, R, renin. Renin is released from these juxtaglomerular cells. So we'll come back to the second bullet in a second. But once renin is released from the juxtaglomerular cells, it's going to start working on the next step in the name. The next step in the name is angiotensin, right? Renin angiotensin aldosterone system. So the angiotensin is going to be formed through a couple steps. The first step is angiotensinogen is going to be cleaved into angiotensin 1. So remember, angiotensinogen comes from the liver, okay? So this coming from the liver is going to get cleaved to angiotensin 1 in the bloodstream, in the systemic circulation, by the renin that was released from where? The granular cells, right? Released from the granular cells, also known as the juxtaglomerular cells. Okay, so once we get angiotensin 1, that angiotensin 1, remember, it's in the bloodstream, it's going to go to the lungs, and this is particularly high yield. Okay, once that angiotensin 1 goes to the lungs, it goes through the pulmonary artery into the pulmonary capillaries, and that angiotensin 1 in the pulmonary vasculature is going to get converted to angiotensin 2. Okay, so we have angiotensinogen released from the liver, cleaved to angiotensin 1 by renin, renin being released from the granular cells of the juxtaglomerular apparatus. When that angiotensinogen gets cleaved, it's going to get cleaved into angiotensin 1 in the bloodstream. Then that angiotensin 1 is going to go to the lungs. In the lungs, it's going to get converted to angiotensin 2. Now, angiotensin 2 is the person that we really care about, because angiotensin 2 is going to do all of the activities. It's going to be mediating all of these events. Okay, so angiotensin 2 is very important. And I also want to add one last kind of caveat. Remember, angiotensinogen is converted to angiotensin 1 by renin. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Okay, so this is where, when we talk about very high yield drugs like angiotensin converting enzyme inhibitors or ACE inhibitors, we're talking about drugs that are going to be inhibiting this enzyme specifically. In other words, inhibiting the conversion of angiotensin 1 to angiotensin 2. So we'll talk about that in a moment. But this is the general pathway. So we start with renin, and then we go on to form angiotensin 2, and then angiotensin 2 is going to direct a lot of the effects, and we'll talk about this in a moment, but it'll eventually lead to aldosterone release. So now let's talk about how do you actually get your blood pressure to go up using the RAS system. Well, we already said the whole process starts with renin, right? We already said it starts with renin, okay? But how do you actually get renin release? What are some things that will stimulate renin release? Well, the first thing is if I have increased sympathetics. Specifically, my sympathetic nervous system can target the juxtaglomerular cells, or the granular cells, through beta-1 receptors, and that is particularly high yield to remember. So my sympathetic nervous system can target the juxtaglomerular cells through beta-1 receptors. Okay, so beta-1 receptors, or anything that stimulates beta-1 receptors, will stimulate renin release. And if I stimulate renin release, right, I'm going to convert more angiotensinogen to angiotensin 1 to angiotensin 2, and so forth, and stimulate this pathway. What else will stimulate renin release? Well, I just told you, we can measure the sodium concentrations inside the distal convoluted tubule. Now, if you have low sodium concentrations, the body is going to interpret that as a very low amount of sodium getting filtered through this afferent arteriole, right? If I have really low glomerular filtration rate, right, if my GFR is very low, okay, I'm going to be filtering less fluid. That might be because there's less fluid coming into the glomerulus. If I'm hemorrhaging, I'm not going to have a lot of fluid coming into the glomerulus, right? I'm not going to have a lot of blood volume. That's going to lower my GFR. My body's going to say, hey, look, I'm not filtering as much fluid. I'm not getting as much sodium into these glomerular capillaries and eventually into the distal convoluted tubule, right? And if I have really low sodium here, my body interprets that as saying, hey, your GFR is low, your blood volume is probably low, we need to increase that, okay? So if the sodium levels are low in the distal convoluted tubule at the site of the macula densa, that will also stimulate renin release, okay, because the body interprets that as having low blood volume. The third thing is if there's a low pressure in the afferent arteriole, okay, so if there's a low pressure, I'm going to put a low pressure in the afferent arteriole, the body will also interpret that as saying, hey, look, the pressure here is really low. Maybe the blood volume is low, the blood pressure is low. What does RAS primarily do? It increases blood pressure. Okay, so maybe I need to increase my pressure. So if the pressure in the afferent arteriole is low, that will also stimulate renin release. These are the big three. Beta-1 receptor stimulation, decreased sodium concentration going to the distal convoluted tubule, and decreased pressure in the afferent arteriole are all classic for causing increases in renin and therefore stimulating the RAS system. Okay, and just to recap this really quickly, so we know renin will help convert angiotensinogen, I'm just going to put AGin here, angiotensinogen into angiotensin 1. And this is going to happen where? It's going to happen in the bloodstream. Now I have my angiotensin 1, it's going to go to the lungs. And I'm going to have angiotensin converting enzyme, right? This is going to be in the lungs. Is going to convert angiotensin 1 into angiotensin 2. And then we're going to put a bunch of, fancy signs here around angiotensin 2 because we know angiotensin 2 is mediating most of the activity. Now, what does angiotensin 2 do directly? We're going to see that in the next slide. The last little tidbit, though, I want to put in here because this can get very confusing. If I took my pulmonary artery, okay, so here's my pulmonary artery. Now, you might be saying, Dr. Vizor, why are you drawing a pulmonary artery in blue? Remember, this is deoxygenated blood. Not all arteries are going to carry oxygenated blood. So pulmonary artery is taking blood away from the heart. It's taking it from the right ventricle to the lungs. This is deoxygenated blood. Now, also in that blood, I'm going to have some angiotensin 1. That's going to go to the lungs. Okay, so eventually we're going to get to my lung capillaries. Let's just draw them in here. We'll put lung capillaries. Okay, so here's my lung capillaries. Now, inside of my lung capillaries, okay, that angiotensin 1 is going to get converted to angiotensin 2. So my AT1 is going to get converted to AT2 by ACE. Okay, and it doesn't necessarily have to be in a capillary, but it's going to happen somewhere, in the vicinity of this area where angiotensin 1 is converted to angiotensin 2. Okay, so if I had a pulmonary vein that's going to my left atrium, this is mostly going to be oxygenated blood, right? So this is my pulmonary vein, okay? And in that pulmonary vein, I'm primarily going to have more of the angiotensin 2. I'm at least going to have a lot more angiotensin 2 than I had in the pulmonary artery. So if you ever get a question and it's asking you, where would you expect to find a higher concentration of angiotensin 2? Well, you'd certainly expect to have a higher concentration in the pulmonary vein than in the pulmonary artery. Don't get confused, right? Pulmonary artery is deoxygenated. It's bringing the angiotensin 1 in. Pulmonary vein oxygenated, bringing it out. So just a tricky concept. Make sure you're sharp on that. All right, let's try and talk about angiotensin 2. Now, angiotensin 2 is a very important target for all of your board exams from this point forward, essentially, because it affects so many different things and it's so frequently tested. So it's really important to know the high yield effects of angiotensin 2. So let's start with the first one. So the first one on here is an increase in vasoconstriction. So it causes an increase in total peripheral resistance. We've definitely talked about how vasoconstriction can cause an increase in total peripheral resistance. And remember, this is primarily going to be affecting, your diastolic blood pressure. Okay, and this is going to happen at the location of the arteriole. So let's take a look at this. So this is the diagram that we've been talking about. You start with angiotensinogen, you get angiotensin 1. ACE is going to convert it to angiotensin 2, and then we have all these effects. That's kind of the position that we're at right now. Now, the first big effect that I want you to remember, this is the number one effect, arteriolar vasoconstriction. It's going to cause increases in blood pressure, right? We're going to constrict at the level of the arterioles. That's where we regulate pressures, okay? So that would increase primarily my diastolic blood pressure, also some of my systolic, but primarily diastolic. The next big thing that I want you to remember is that it also causes increases in norepinephrine release and availability. So it's facilitating the release of norepinephrine. So we get more norepinephrine released, and it's going to inhibit the reuptake. So there's more norepinephrine lasting a longer amount of time, more available in the neuronal tissue. And remember, norepinephrine has multiple effects. It has beta-1 effects. It has alpha-1 effects. Remember what beta-1 does. Beta-1 is going to stimulate the juxtaglomerular apparatus to release renin from the granular cells. Okay, but alpha-1 effects, which is one of the primary effects of norepinephrine, those effects are also going to lead to increases in vasoconstriction. Okay, so the second action of angiotensin II is going to be increasing sympathetic activity, specifically norepinephrine, some epinephrine potentially as well. Third major effect of angiotensin II is to increase sodium reabsorption and blood volume. So this is where we take it kind of to the next step. So essentially what we're saying here is that we're going to stimulate the adrenal gland to release aldosterone. Aldosterone is going to primarily cause us to have increases in sodium reabsorption and potassium excretion. So you have to be really careful when you start talking about, reabsorption and that kind of thing, because it can get very confusing. So let's just recap this. So, let's just say I have my, glomerulus over here. Okay, so here's my glomerulus. Eventually that's going to form my proximal convoluted tubule, okay, and then that's going to go on to form my, you're going to have your loop of Henle, right? You're going to have your distal convoluted tubule, and eventually, right, you get to your collecting duct. So this whole structure, when we say that tubule lumen, we're talking about this structure here, okay? Everything inside this tube that eventually goes on to make urine. So that is the lumen. When I say the lumen, that's what we're talking about. So basically everything inside of here, again, is going on to make urine. Now, outside of this, right, I might have some interstitial space, and then I might have some of my blood vessels, okay? So I might have, a capillary or some vascular structure here, okay? So if I say that there's sodium reabsorption, essentially what we're saying is the sodium is going from the kidney lumen into the bloodstream, okay, into the bloodstream. And if the sodium goes into the bloodstream, again, water follows salt. Remember that, water follows salt. So if the sodium goes in the bloodstream, this is going to increase my total blood volume, which is eventually going to end up increasing my preload, right? So that's what aldosterone is doing. Aldosterone is going to be stimulating, like we said, it's going to stimulate sodium reabsorption, like you see in the image here. It's going to go from the tubule into the bloodstream. So we're reabsorbing more sodium, increasing our sodium concentration, water follows salt, increasing the blood volume. So aldosterone is helping us increase our preload in our blood volume. How does it do this? It does this in exchange for potassium. So the potassium that's in the blood is going to come out of the blood, go into the kidney lumen, and then where's it going to go? Out in the urine. So we are reabsorbing sodium, right? We're reabsorbing it into the bloodstream, and we're excreting potassium. Okay, so there's a lot more to this process that we're going to talk about in the kidney lectures, but that's the general concept of what aldosterone is doing. It's increasing preload and total blood volume at the expense of potassium. So your potassium levels will come down, your sodium levels essentially will come up. And where do we stimulate aldosterone release? We stimulate it from the zona glomerulosa. Remember, if you're looking at your adrenal cortex, right, your adrenal gland cortex, you're looking at three layers: GFR, glomerulosa fasciculata reticularis, salt, sugar, and sex hormones. Okay, so that's how I remember it. So remember, G is for salt. That's aldosterone. Why salt? Sodium, right? Sodium reabsorption, sodium is salt. Recapping it, we're essentially saying that angiotensin II stimulates the zona glomerulosa to release aldosterone, which results in increases in sodium reabsorption and blood volume at the expense of potassium. Finally, the last thing on here is that angiotensin II will also stimulate ADH release. Now, when you think about ADH, remember there's a couple names for this. There's vasopressin, antidiuretic hormone. There's really two things that stimulate the release of ADH. Now, we just said that the RAS system can stimulate it. But when you're thinking about this on board questions, I don't want you to remember this as like the first thing. This is like the last thing. Once you have all the facts down, you feel like you're a pro, then you can remember that the RAS system stimulates ADH release, but it's not as frequently tested because the major regulator, when you think about ADH release, is primarily going to be, when you're talking about osmolality. When the hypothalamus detects that the osmolality is very high, in other words, we might have really low blood volume, for example, maybe we're really dehydrated, we're going to stimulate ADH release so that we can reabsorb water from the collecting duct, right? Primarily water. This doesn't have anything to do with sodium reabsorption, okay? ADH release is just about basically having more holes open up in the collecting duct so we can strictly absorb water because the osmolality in the blood is high. Okay, so that's really how I want you to think about it. It can get confusing here, but I'm including it for completeness sake. But again, I would remember that one last. The other stuff on here is the big stuff to remember. And you can see the depiction of that down here. ADH secretion from the posterior pituitary gland, typically in response to high osmolality or decreased blood volume, okay? That will cause increases in water reabsorption at the collecting duct. Okay, so again, going back to our glomerulus. So when we have our glomerulus, we have some blood that comes in, okay? And then we have some glomerular capillaries, and then we have some blood that goes out. Okay, and the simplest way to kind of describe this is, like I said earlier, we have an afferent arteriole. Okay, so here's the afferent arteriole. Here's the efferent arteriole. And then this, like we said, this is going to be the capillaries, the glomerular capillaries. And then we have our glomerulus here, right? This is going to be our glomerulus. And this will eventually go on to form, your proximal convoluted tubule, your distal convoluted tubule, etc. Okay, and we're going to have our filtering happening here. And like I said, I'm going to go into this in a lot more detail, in the future videos. But basically, what I want to the point I want to get across here is that there's certain agents that can adjust this afferent and efferent arteriole. Like, let me give you an example. Think of this as just like a pipe, right? If I make this pipe bigger, based on some of the flow physiology we talked about, if I make this pipe bigger, I'm going to have more flow because I'm going to have a greater diameter. Remember Poiseuille's law. If I take the radius, remember that's to the fourth power. If I adjust the radius of this vessel, I can significantly impact the flow. If I increase the radius, I'm going to have a lot more flow. Okay, so if I increase the radius here, I'm going to get a lot more flow through the afferent arteriole. And conversely, if I get more flow, I'm also going to get more filtration. So the bottom line is, if I increase the diameter of the afferent arteriole, what's going to happen? I'm going to get increases in GFR. Okay, so I'm going to get more filtration. If I get more filtration, I'm going to have more sodium reaching the macula densa. So I'm going to get inhibition of RAS. So that's like one way to kind of put this all together. If I had the reverse happen, let's say that I narrowed down the afferent arteriole. In other words, another way to say that, I did vasoconstriction of the afferent arteriole. Let's say I vasoconstricted it. I made it really small. Okay, so if I have vasoconstriction, I'm decreasing the radius of the afferent arteriole. Okay, and in that situation, I would decrease my GFR. I would decrease sodium delivery to the macula densa and stimulate the RAS system. Okay, so this is another way to think about it. In general, when we look at kidney function, typically we're not really looking at sodium delivery, but we're looking at creatinine. Okay, and I know I'm kind of turning this into a kidney lecture. I don't want to talk too much about that. But the creatinine is filtered at the glomerulus. If I have a higher filtration rate, I'm going to filter more creatinine. If I have a lower filtration rate, I'm going to filter less. And so I'm going to have a higher amount left over in the blood, right, if I have a lower GFR. Okay, so if a lower GFR is generally going to be associated with a higher creatinine. So we'll go into more detail on this in the kidney lectures, but this is the concept. Now, the reason that I'm bringing this up now is because certain drugs that we're going to talk about affect this. Which drugs specifically? Well, okay, remember prostaglandins, PGs, prostaglandins, those are going to dilate this afferent arteriole. Prostaglandins, by dilating the afferent arteriole, are actually going to have inhibitory effects on the RAS system. But in general, most people don't take prostaglandins as a drug, but one drug that's frequently used is NSAIDs, like aspirin, for example. Okay, now NSAIDs, non-steroidal anti-inflammatory drugs, these are actually going to have effects on cyclooxygenase, which is going to inhibit prostaglandins. Okay, so NSAIDs are going to inhibit prostaglandins, right? And remember, prostaglandins will dilate the afferent arteriole. So NSAIDs, because they inhibit prostaglandins, will actually constrict the afferent arteriole. So if I constrict the afferent arteriole, what is the effect that NSAIDs are going to have? They're going to increase RAS stimulation because they're decreasing the lumen of the afferent arteriole. So again, NSAIDs decrease the GFR. So this is why a lot of times also patients that have kidney disease, you got to be really careful giving them NSAIDs because maybe their GFR is already low, and now you're constricting their afferent arteriole. You'll be in the sense that you're going to have even lower GFR. Now the other thing, right, that we commonly talk about, and we will talk about in this video, is going to be angiotensin II. Okay, so we already said angiotensin II is going to have effects at the kidney. And one of the major effects that angiotensin II is going to have is actually it's going to cause vasoconstriction of the efferent arteriole. Now, what happens if I constrict the efferent arteriole? Well, we know what happens when I change the flow or the vessel diameter in the afferent arteriole. Now, the efferent arteriole is the blood that's coming out of the glomerulus. So the afferent is the blood coming in, right? And the efferent is the blood coming out. If I constrict the blood that's coming out, I'm going to get less flow out of this arteriole. So there's going to be more blood kind of stuck in these capillaries, right? Because the flow is going to be lower because I constricted, I pinched down on the efferent arteriole. So angiotensin II will constrict this area, okay? And so angiotensin II, by constricting the efferent arteriole, decreasing the diameter of the efferent arteriole, it will increase the GFR, right? It will increase the amount of sodium getting to the macula densa, and in doing so, it will decrease the RAS system. And take a moment and think about that. Does that make logical sense? If you have a lot of angiotensin II around, do you want it to tune down the RAS system? The answer is absolutely, because angiotensin II is one of the last mediators of the RAS system. Right? When I stimulate the RAS system, I end up making angiotensin II. Well, this is the autoregulation. Angiotensin II feeds back by constricting the efferent arteriole so that we have less of it around, right? If angiotensin did the opposite, what would happen? Well, you just have constant positive feedback of the RAS system. That's not what we want, right? We want to keep things physiologically regulated. So this is kind of like the negative feedback. Now, if I give somebody a drug that causes them to have low angiotensin II levels, what will happen at the efferent arteriole? Well, if I have a drug that decreases the angiotensin II levels, I'm going to get dilation of the efferent arteriole, right? So if I have dilation of the efferent arteriole, if I increase the diameter, I think you know where this is going, I'm going to decrease my GFR because more blood is now allowed to leave. So as soon as blood comes in, if this is really dilated, it's going to come right out. That's going to cause me to have less sodium filtered, right? And that's going to stimulate the RAS system. If I gave somebody an ACE inhibitor, an angiotensin converting enzyme inhibitor drug like lisinopril, for example, that would cause dilation. Here, that would decrease my GFR. Okay, this is why when you put a patient on a medication like an ACE inhibitor, their creatinine goes up. And we'll talk about this for step 2. But this is why, if you start somebody on a medication like an ACE inhibitor, some people in the medical field might say, oh my goodness, look, their creatinine went up 10%, 20% from what it was before. Maybe they have a kidney injury from the ACE inhibitor. That's not true, right? The ACE inhibitor causes the creatinine to go up, not because there's kidney damage, but because you're dilating the efferent arteriole. Okay, and believe me, even in my experience, people still have a hard time understanding that. If you understand the mechanisms of what's happening, it actually makes sense. So ACE inhibitors in general are actually protective on the kidney in a lot of situations. That's because you're taking more pressure off of these capillaries by dilating the efferent arteriole. Okay, you're decreasing the glomerular filtration rate. Yes, that's true, but you're also taking some of the pressure off. If a patient has hypertension, okay, and a patient has really high pressures coming into this glomerulus, and you dilate this efferent arteriole, now you're relieving some of that pressure. The cost of that is decreasing the GFR. If a patient is hypotensive, an ACE inhibitor is going to be a really bad idea, right? Or if the patient has a constricted afferent arteriole, an ACE inhibitor is not going to be the ideal medication. But if a patient is hypertensive and has high pressures coming in, you can dilate this vessel, get some pressure off, and that's ideally why they're partly used for hypertension. They're also nephroprotective in that sense. All right, so let's talk a little bit about the natriuretic peptides. So the natriuretic peptides, if you can just remember that these chemical targets are really just the opposite of your RAS system. So in the RAS system, which I'm going to leave it up here for a second so we can compare these. But in the RAS system, the whole idea was to increase blood pressure. Okay, so these natriuretic peptides, what do you think the concept here is? The concept is decrease blood pressure. Okay, so the natriuretic peptides are finding ways to decrease the blood pressure. Well, how did we increase the blood pressure to begin with the RAS system? We increased the preload, right? Remember I said we increased the preload with the RAS system? And what else did we do? We increased the TPR. Well, let's see what we can do about that. Okay, so the natriuretic peptides are going to do the opposite. They are going to decrease the preload. Now, how can you decrease preload? You have to decrease blood volume. So the natriuretic peptides, when they see a lot of volume around, they're going to allow for diuresis. Now, diuresis is just referring to, remember when I showed you that kidney lumen, right? I said, here's the kidney lumen, right? And then I said, here's some blood vessel down over here. And all of this stuff in the kidney lumen is eventually going to go out in the urine. All of these natriuretic peptides, ANP, BNP, what they're doing is they're allowing more water, more fluid, I should say, to stay in the kidney tubules so that they can go out in the urine. That's what diuresis essentially is. So we're diuresing, we're having more fluid go out into the kidney lumen and eventually out into the urine. And part of that has to do with keeping sodium in that kidney lumen, right? If this is my kidney lumen, this is eventually going out into the urine. I need to keep the sodium here because that's going to keep the water also here, right? If I keep the sodium in the kidney lumen, that's going to keep the water there. Remember what aldosterone did. Aldosterone took this sodium and put it over into the blood vessels, right? So the aldosterone put it over here. That's what aldosterone did. But we don't want that to happen, right? We want to keep the sodium. If we're a natriuretic peptide, we want to keep the sodium right here in the kidney lumen so that we can excrete it. That's the concept, okay? Because we want to diurese. We want to get the blood volume down. We want to get the blood pressure down. That's the number one goal with a natriuretic peptide, get the blood pressure down. So that's how we decrease the preload. We go through diuresis. Some of that is mediated by cGMP, which I'll talk about in a minute. And the other thing is we also said that the RAS system caused us to have a high TPR, okay? So we want to get the TPR down. Okay, so how can I get the TPR down? Well, if I undergo vasodilation, right? Just the opposite of vasoconstriction. How do we vasodilate? Well, if you've been watching the video so far, you probably already know the answer to this. We use cGMP. What does cGMP do? cGMP stimulates who? Myosin light chain phosphatase. What does that do? Myosin light chain phosphatase is a phosphatase. It takes phosphate off of myosin light chain, right? We already talked about all of this. We're just recapping. It's all coming full circle. We take the phosphate off, and we're just left with myosin light chain. This is going to lead to more relaxation, right? If I had myosin light chain kinase, that would cause more phosphorylation of myosin light chain because it's a kinase. Kinases phosphorylate, phosphatases dephosphorylate. So we talked about all of that in the previous videos, and it's all the same thing, right? cGMP, increases in cGMP are responsible for vasodilation. And we saw this when we talked about nitric oxide. It was a classic example. Nitric oxide caused increased levels of cGMP that led to vasodilation. Now, you might be saying, well, wait a second, Dr. Viso, is this vasodilation of just arterioles, or is it in the venous system? Because remember, when we talked about nitric oxide, we said that also had effects on the veins. In fact, it was primarily acting on the veins. And I would say that the answer to your question is it also affects the veins. It affects the arterioles and the veins. So if I increase cGMP on the venous side, what is that going to do to my preload? The answer is it's going to decrease my preload. If I dilate the veins on the venous side, again, we already talked about this 3 or 4 times in the last few videos. You can always go back there and check those out. But what we said is if we dilate the veins on the venous side, that's going to increase my compliance of those veins so they can house more blood, right? The veins are my refrigerator of blood. It's all stored over there and for when I need it. And when I dilate those veins, I allow more blood to be stored. And that's going to decrease my preload because I'm going to get less blood going back to the heart, right? So that's what's happening here. The increases in cGMP are responsible for further decreases in preload and decrease in TPR, overall leading to a decrease in blood pressure. Okay, remember cGMP is associated with atrial natriuretic peptide and brain natriuretic peptide. And these guys are the anti-RAS. Okay, they're the anti-RAS. How does atrial natriuretic peptide and brain natriuretic peptide even know that the blood volume is high? And we already talked about how the RAS system works, right? The RAS system was able to detect sodium concentrations in the distal convoluted tubule pressures in the afferent arteriole or be stimulated via sympathetic stimulation via beta 1. But these receptors, how do they know that the opposite is happening, that the blood volume is high? They detect the atrial and ventricular pressures. When there's a lot of filling, when there's a lot of volume in the heart, in the atrium, these peptides will start to get released. So when there's a lot of blood volume, they get released, and their goal is decrease preload, decrease TPR, right? So they're counteracting those effects. So if you have a patient that's volume overloaded, if they have cardiomegaly and they're all backed up, they have left atrial dilation, heart failure, whatever it is, these patients are going to have elevations in their atrial natriuretic peptide and brain natriuretic peptide. And you might be saying, okay, I get all that, but why is it called natriuretic peptide? This is referring to, natriuretic is referring to the first two letters. That tells you it right there, sodium, okay? And you might be saying, well, what does sodium have to do with it? Well, sodium has to stay in the kidney lumen so that we can get diuresis. So it's named for, and I'm gonna write this here, the natriuresis that has to occur. In other words, sodium has to go out through the urine, causing diuresis, which is water that's also following going out through the urine. By doing that, we get the pressures down, we get the blood volume down. Again, what I wrote here is that these peptides are frequently elevated in heart failure. They have to compensate temporarily for angiotensin II in heart failure. Let's just say that I have a patient that has a really low ejection fraction. Let's say their ejection fraction is 10%. This is really low. But let's just say they have an ejection fraction of 10%, okay? Now, this person with an ejection fraction of 10%, they're not really pumping out any blood. So what's going to happen? Well, if this is my left ventricle, right, and I'm pumping blood out to my aorta, okay, I'm barely pumping any blood out, just a little bit of blood. So all the blood in the left ventricle and left atrium is going to get backed up, and they're going to get really dilated, okay, because we're really not pumping out very much blood. So it's just going to back up, and it's going to back up into the lungs, and then I'm going to get pulmonary edema in my lungs, right? So I'm going to get all this pulmonary edema, and it's going to continue to back up in my right ventricle, right? All this blood is backing up because I can't eject it out, right? It's going to back up into my right atrium, okay? And then eventually it's going to back up through my veins in my inferior and superior vena cava. Anyway, my point here is that while this process is happening over months or over years, the actual blood that's getting ejected, right, that's eventually going to go through my aorta and eventually to my kidneys. Okay, so it's eventually going to go to my kidneys. And in my kidneys, we know we have our juxtaglomerular apparatus, which has an afferent arteriole that's detecting the pressure that's coming in. If I'm barely getting out any blood, if I have a 10% ejection fraction, okay, and my pressures are going to be pretty low, I'm not going to have a ton of pressure coming out of that aorta. And so my juxtaglomerular apparatus is going to recognize that and say, hey, these pressures are low. We need to kick up the RAS system. Okay, and that's because this heart failure, and in real life, right, somebody doesn't go straight to an ejection fraction of 10%, but over time that can happen. And so then what happens is the kidneys are saying, okay, look, we're not getting a lot of perfusion here from the heart, so we need to kick up the RAS system. And so the RAS system is going to get stimulated for multiple effects. On one side, it's going to get stimulated because there's low perfusion going to the juxtaglomerular apparatus. On another side, your baroreceptors that we talked about in the last video, your baroreceptors are not going to be getting a lot of pressure either, and so they're going to be stimulating the sympathetic nervous system. The sympathetic nervous system is going to release epinephrine, norepinephrine. They're going to bind to beta 1 receptors, which will also stimulate the RAS system, right? And then on top of that, you're going to have a low GFR because you have low pressures coming in, so the macula densa is going to see low sodium concentrations, and that's also going to stimulate the RAS system. So in this patient that has heart failure, an ejection fraction of 10%, the RAS system is going to be very active, okay? And so the RAS system is going to say, look, angiotensin II, you're my primary mediator. I want you to increase the preload, okay? Increase the preload and increase the TPR. So we're going to have vasoconstriction, right? We're going to constrict down on all of these arterioles out here. We're going to pinch down on them to try and get the pressures up. And we're going to increase our preload using aldosterone. Okay, if we have aldosterone around, we're just going to increase our sodium reabsorption. Here's the problem with that. Now you're getting more and more sodium in, right? You're increasing the blood volume, but look, you're already backed up. You're already full of blood volume everywhere. And so now you're bringing in even more blood volume. So now things are getting even more dilated. And guess what? You can't pump any of this out because your heart doesn't have a good pump, right? Your ejection fraction is only 10%. So things are getting backed up at an even faster rate now because you're retaining sodium, you're retaining more blood volume, things are getting more backed up, you can't pump them out. And guess what? Not only are they getting more backed up, but now you're trying to pump against a smaller pipe with higher resistance. So even less blood is actually getting through the pipe. And so now the RAS system is getting even higher. And you can see this is a vicious cycle. This is heart failure. If you understand this, this is systolic heart failure. Diastolic heart failure, the big difference is that this ventricle, instead of it not pumping, it just has really bad compliance. And so it can't accommodate higher levels of preload. And then you can end up getting blood backed up for that reason. In any sense, though, this is essentially a heart failure talk, kind of very simplified in this lecture, and I'll go through heart failure, in more detail, but that's essentially what's going on. And this is why this whole process can be very problematic if not addressed very early.